Good day, doctors. Today we will discuss prevention of dentin hypersensitivity. Lecturer Makusheva Natalia Vячеславовна, Department of Pediatric Dentistry and Orthodontics. Goal of the lecture: to study the causes and methods of prevention of dental hyperesthesia or hypersensitivity. Lecture questions: dentin hyperesthesia, theories of dentin hyperesthesia, clinic and diagnosis of dental hyperesthesia, methods for the prevention of dentin hyperesthesia. Relevance: tooth hypersensitivity is one of the most common dental problems, and according to the WHO, its prevalence is steadily increasing. Every fifth adult in the world, mostly women, at least once in his life experiences a sudden, clearly localized, acute pain reaction that occurs when external stimuli affect the teeth. Definition: hyperesthesia is an increased sensitivity of the tooth tissues to mechanical, chemical, and temperature irritants. DENTIN hypersensitivity classification. DENTIN hypersensitivity we can divide to local and systemic. Local, accompanied by sensitivity in a small number of teeth. Systemic, present in many teeth at the same time. Dental hypersensitivity classification according to further. Group A, by relevance. First one, limited form, usually manifests itself in the area of individual of several teeth, more often in the presence of single carious cavities, with wedged sharp defects, and also after preparation of teeth for artificial crowns and inlays. Two, generalized form, manifests itself in the area of most or all of the teeth, more often when the necks and roots of teeth are exposed in case of periodontal diseases. Pathological wear of teeth, with multiply dental caries, with multiply and progressive form of tooth erosion. Group B, by origin. First, dentin hypersensitivity associated with the loss of dental hard tissues. In the area of carious cavities, arising after the preparation of tooth tissue for artificial crowns, inlays, etc. concomitant pathological abrasion of hard tooth tissue, and wedge-shaped defects, with erosion of hard dental tissues. Two, dental hyperesthesia not associated with loss of dental hard tissue. Hyperesthesia of dentin of exposed necks and roots of teeth with periodontal diseases and other periodontal diseases. Hyperesthesia of dentin of intact teeth, functional hyperesthesia, accompanying general disorders in the body. Group C. According to the clinical course. Grade 1. Tooth tissue react to temperature, cold and hot stimulus, and the threshold of dentin electroexcitability is 5 to 8 microampere. Grade 2. Tooth tissue react on temperature and chemical, salty, sweet, sour, bitter irritants. The threshold of electroexcitability of dentin is from 3 to 5 microampere. Grade 3. Tooth tissue react to all types of stimuli, including tactile. The threshold of electroexcitability of dentin reacts from 1.5 to 3.5 microampere. Risk factors for tooth hypersensitivity. It may be general and local, causing local or systematic sensitivity. Local factors happens when caries may be in one specific area, abrasion of tooth tissue when the loss of enamel reached the dentin border, erosion, wedge-shaped defect, gum recession, traumatic incisure of hard tissue of teeth, after treatment of bleaching, after traumatic occupational hygiene. Sometimes sharp sensitivity is observed with already insignificant exposure necks of teeth by from 1 to 3 millimeters. Systemic factors is associated with psychoneurosis, endocrinopathies, disease of the gastrointestinal tract, metabolic disorders, are related hormonal changes and disorders, infectious and other concomitant diseases. A bit of histologies. Etiopathogenesis. Normally, dentin is tightly covered with enamel, and the cement of the tooth with the gum. This protects the dentin from environmental irritants. The enamel in the cervical region is less mineralized and has less thickness. So, hypersensitivity is most common in their areas. Tooth enamel is an insensitive tissue, so we are talking about the sensitivity of dentin, not tooth enamel. Dentin is composed of layers: pretubular dentin, intertubular dentin, and predentin. It near of the nervous ends from pulp. Dentin consists of a basic substance permeated by many thin dental tubules containing processes of odontoblast cells, the bodies of which are located in the pulp. Dentin tubules diverge from the pulp of the tooth to the periphery in a radial direction. The sensory mechanism of dentin is not well understood, but it is believed that there are nerve endings in the dental tubulins and outer layers of the pulp. Dentin consists of a basic substance permeated by many thin dental tubules containing processes of odontoblast cells, the bodies of which are located in the pulp. Dentin tubules diverge from the pulp of the tooth to the periphery in a radial direction. The sensory mechanism of dentin is not well understood, but it is believed that there are nerve endings in the dental tubulins and outer layers of the pulp. Dentin hypersensitivity theories. There are 5 theories of the occurrence of dental sensitivity: hydrodynamic, receptor, odontoblastic, threshold, nerve reflex theory. Receptor theory. It proceeds from fact that the nerve endings of those nerves that are associated with the pulp are located in dentin, and stimuli can directly affect them. But nerve endings do not extend along the anti-late of the tubulus and occupy only 10% of the pulp of some dental tubulus. Odontoblastic theory suggests that odontoblast cells, acting as receptors, receive and transmit stimuli to the ends of sensory nerves in the pulp region of the dental tubulus. But odontoblasts are not genetically related to nerve tissue, and their process do not extend to entry late of the tubuli. Even if odontoblasts die off, sensitivity remains as long as the tubulus containing fluid are open. Threshold theory proceeds from the fact that the dentin sensitivity, the pain threshold is low, for example with inflammation. But despite effective blockade of the dental tubulus, dentin sensitivity can sometimes persist. This suggests that the other mechanisms can also be involved in the activation of the nerve instead of or in additional to the hydrodynamic process. Nervous reflex theory. Dentin sensitivity is based on the mechanism of external stimuli conduction by the dentin receptor apparatus. Ion exchange process between salvia and tooth enamel are disrupted. Phosphorus and calcium compounds entering the body are not completely absorbed or do not enter the surface layer of enamel and dentin. The mineralization process is disrupted. But not all people with hypersensitivity have enamel demineralization. Hydrodynamic theory. Dentinal tubuli as a capillary tube containing fluid or pulp transudate. It is easily displaced by air, heat, cold, probe tip, etc. The movement of fluid in the tubulus leads to a change in pressure in the dentin and, as a result, increases the activity of the nerve endings in the pulp of dental tubulus. Thus, as a result of the thinning of the enamel layer or its disappearance, dentin is exposed. Dentinal tubulus open, intracanal pressure changes, and from the external openings of the dental tubulus there is an outflow of dental fluid at an increased rate, which causes irritation of the nerve fibers. Currently, the overwhelming majority of researchers adhere to the hydrodynamic theory of the owners of the tooth hypersensitivity. Further, the tubules are dehydrated, and unprotected nerve endings react with a sharp manifestation of pain to any external influence. Restoration of intratubular pressure when the dentin tubules are closed leads to rapid elimination of pain sensitivity. The most common and severe irritant to these teeth is cold. A less pronounced reaction is noted to an increased temperature, since hot temperature stimulates a relatively slow internal movement of fluid in dentin. Studies using electronic scanning and dentin-penetrating stains shows that the difference in the number and diameter of dental tubulus results in a 16-fold increase in dental fluid flow rate. With increased sensitivity, there is a greater number, approximately 8 times compared to the norm, of open dentinal tubulus. Moreover, their diameter is 2 times the diameter of the tubulus of intact dentin. DENTIN Hypersensitivity Clinic. Patients with sensitive teeth have problems with oral hygiene because of pain occurs when brushing teeth. Then this leads to excess plaque deposition and caries, inflammation and destruction of periodontal tissue occur. Pathological changes in the periodontium lead to gingival recession, which results in increased hypersensitivity. Thus, a continuous circle arises. The mechanism is more complicated in microscopically intact enamel, most often observed in general concomitant pathology of the body. In all likelihood, in some cases, there are still microcracks in the enamel, through which irritants can penetrate deeper. What matters is the number and diameter of the lumen of the dental tubulus, which depend on the individual characteristics of the organisms, plus the threshold of pain sensitivity of a person matters. If it is reduced, then the sensitivity increased. Then the pain is felt even by those whose enamel and dentin are not damaged. Differential diagnosis. Differential diagnosis will depend on what form of hypersensitivity the patient has. If this is secondary hypersensitivity, it means consequence of any disease, then differentiate the underlying disease, treat, and hyperesthesia as a symptom will not longer bother. If hyperesthesia is primary, functional, on intact teeth, differentiating from pulpitis. Similarly, pulpitis and hyperesthesia. Similarly, sharp pain, the difficulty of identifying a diseased tooth. The diagnosis is based on the duration of the pain and the electrical excitability of the pulp. With pulpitis, pain long occurs at night. Electrical excitability over 12 microampere. With hyperesthesia, pain short-term and in any time. Electrical excitability from 2 to 6 microampere. Prevention of dental hypersensitivity. Prevention of dentin hypersensitivity can be professional and individual. Professional prevention of dental hypersensitivity will consist of oral cavity sanitation, professional oral hygiene, deep fluoridation, and mineralizing therapy. Sanation of the oral cavity. From the Latin sanatio, treatment, health improvement, is a complex of the therapeutic and prophylactic measures to improve the health of the oral cavity, identify and eliminate pathological changes and functional disorders of the oral cavity organs, and prevent dental diseases. Oral cavity sanation, it is the main component of the dental prophylaxis. Oral hygiene is a set of measures aimed at preventing and improving the oral cavity. Professional oral hygiene, a scientifically based system of preventive measures performed by a dentist, dental hygienist, aimed at improving the organs and tissues of the oral cavity and preventing the onset and progression of dental diseases. For the first time, professional clinic as a component of the program for the prevention of caries in inflammatory periodontal diseases was proposed by Axelsson and Lindke at 1970. Professional oral hygiene is a scientifically based system of preventive measures carried out by a dentist, a hygienist, aimed at improving the organs and tissue of the oral cavity and preventing the onset and progression of the dental diseases. You need to understand that the professional cleaning is just a stage of professional hygiene. Don't confuse the two. Professional dental cleaning is through removal of soft and hard dental plaque from all surfaces of the teeth and subsequent treatment of teeth and gums with prophylactic agents. Professional dental cleaning is through removal of soft and hard dental plaque from all surfaces of the teeth and subsequent treatment of teeth and gums with prophylactic agents. Professional teeth cleaning, followed by fluoridation or remineralizing therapy for the prevention of diseases, is recommended to be carried out 2 times a year. If the patient has bad habits, such as smoking, or general diseases that affect the composition of salvia, professional cleaning is recommended once every 3 months. Deep fluoridation. The efficacy of topical fluoride depends on the concentration of fluoride used, the frequency with which it is applied on the duration of application, the specific fluoride compound used. Mechanism of action: fluoride ions. Fluoride ions, when substituted into the hydroxyapatite crystals, fit more perfectly than do hydroxyl ions. Also, the greater bonding potential of fluoride makes the apatite crystal more compact and more stable, thereby more resistant to the acid solution. When concentrated topical fluoride agents react with the enamel, there is formation of calcium fluoride. Commonly used topical fluoride agents include sodium fluoride, sodium monofluorophosphate, stannous fluoride, and aminofluoride, Olaflur. Classification of deep fluoridation drug. Aqueous solution, sodium fluoride 2% and stannous fluoride 8%. Fluoride gels, acidulated phosphate fluoride 1.23%. Fluoride varnishes are Durafat, Fluoro Protector, Cavity Shield, Me Varnish, etc. Once more we have fluoride prophylactic pastes and restorative material containing fluoride. Mechanism of action of sodium fluoride. When sodium fluoride solution is applied on the tooth surface, it reacts with hydroxylapatite crystals rapidly to form calcium fluoride. At first, the reaction goes quickly, then it decreases. This is called suppression. The calcium fluoride reacts with hydroxyapatite to form fluoridate hydroxyapatite. The concentration of fluorine in the surface layer increases. This increases the concentration of surface fluoride, making the tooth structure more stable and surface more resistant to caries attack. It also helps in remineralization of the initial decalcified areas. Aqueous solution for deep fluoridation. In order to prevent the onset and development of hypersensitivity of dental hard tissue, patients should maintain oral hygiene by following the correct brushing technique. Contraindication for aqueous solution for deep fluoridation are not recommended for children under 6 years of age. Inability to rinse your mouth. Method of rinsing aqueous solution for deep fluoridation. In the evening, before bedtime, after brushing teeth, hold the rinse from 1 to 2 minutes with using 5 or 7 milliliters of solution sodium fluoride. Method of application sodium fluoride for deep fluoridation. First, cleaning and polishing of teeth is done. Teeth are isolated with cotton rolls and dried with compressed air. Teeth can be selected quadrant-wise. 2% aqueous natrium fluoride solution is applied with cotton applicator for 3 minutes. Procedure is repeated for remaining quadrant until all the teeth are treated. Second, third, and fourth application are recommended at intervals of approximately 1 week, and they are preceded by cleaning and polishing. Patient is advised to avoid rinsing, drinking, and eating for next half hour. It can be prepared by dissolving 1.2 gram of powder in 10 milliliters of distilled water. Professional gels for deep fluoridation. Fluoride gels and foams contain a high concentration of fluoride, typically up to 20 mg on gram fluoride. Gel maybe contains sodium fluoride, amino fluoride, phosphate fluoride. The 4-minute application of fluoride gel is recommended based on studies of enamel fluoride uptake. When contact time is reduced to 1 minute, enamel fluoride uptake is significantly less. Method of applying gels for deep fluoridation. First one, good oral hygiene. Then injection of gel into standard disposable spoons or individual mouth guards. A quarter filled with gel and overlay on the teeth of the upper and lower jaw. Use of salvia ejectors. Exposure time 4 minutes. Abstain from food and drink for 30 minutes. Repeated of procedure depends on from individual risk of caries and from therapeutic effect. 4-5 applications are performed for 1 milliliter, repeated after 3 months. Professional varnishes for deep fluoridation. A fluoride varnish is a professionally applied adherent material. It is not intended to be permanent as a facial sealant. The purpose is to hold fluoride in close contact with the tooth for a period of time. They permit the application of high fluoride concentration in small amounts of material. Method of applying fluorinated professional varnishes. Rational oral hygiene, tooth drying, thin coating. After the procedure, don't eat or drink for a half hour. Refrain from eating solid food and brushing your teeth for 1 day. Remineralizing therapy. Remineralizing therapy is a modern therapeutic and restorative technique that helps to bring the mineral composition of tooth enamel back to normal. Remineralizing mixtures are administered by application, electro and phonophoresis. Remineralizing drugs are divided into solutions and gels. Method of remineralizing therapy. Before the procedure, the teeth are thoroughly cleaned of plaque, dried, then tampons soaked in 10 calcium gluconate solution are applied to the enamel affected area for 15–20 minutes, changing them every 5 minutes. In the middle of the procedure, after 3 times with gluconate calcium, and at the end of the procedure, a cotton swab moistened with 0.2% sodium fluoride solution is applied to the treated tooth surface for 2–3 minutes. After completing the entry procedure, it is not recommended to eat for 2 hours. The course of remineralizing therapy consists of 20 applications which are carried out daily or every other day. After completing the course of remineralizing therapy, the surface of the teeth is expediently covered with fluoride varnish. A repeated course of treatment is indicated after 5–6 months. You can inject 10% calcium gluconate solution and 0.2% sodium fluoride solution into the surface layer of enamel using electrophoresis or electrophoresis. Borowski-Leod method of remineralizing therapy. Consequently, applications are carried out with 10% calcium gluconate solution for 15 minutes, 3 times for 5 minutes, and 2% aqueous sodium fluoride solution for 3 minutes. The duration of the course is on average 15 procedures daily or every other day until the focal demineralization spots disappear or hypersensitivity of dentin is disappear. Borowski-Volkov method remineralizing therapy. A two-component solution is used, containing of a 10% solution of calcium nitrate and 10% solution of acidic ammonium phosphate. Each of these solutions is applied sequentially for 3 minutes. During 5-7 procedures on the enamel surface and in the microscopes of the subsurface layer, a poorly soluble substance, brigade, is formed, which is the source of calcium and phosphorus ions necessary for remineralization of the decalcified enamel area. This technique is effective in the treatment of hyperesthesia of hard tooth tissues. The procedures are carried out until the hypersensitivity disappears. Remineralizing solutions for remineralizing therapy. 10% calcium gluconate solution. To carry out remineralizing therapy, a 10% solution of calcium gluconate and 0.2% sodium fluoride solution are used. Solutions alternate with each other. The introduction can be done both by application and by electrophoresis. Remadentum. Remedent, a preparation obtained from enamel bones, contains a complex of macro and micro elements necessary for the remineralizing of enamel. Approximate elemental composition: calcium, phosphorus, magnesium, potassium, sodium, chlorine, organic matter, trace elements. Remedant is used in the form of application 3% solution for rinsing 1.5% solution. The effectiveness of prophylactic use of Remedant is up to 50% reduction of dental caries. The application lasts 20 minutes. The powder is dissolved in 100 ml of boiled or distilled water. Cotton swabs, abundantly moistened with the solution, are applied to thoroughly clean teeth. Stages: cleaning teeth, isolation from salvia, 3 repeated application of 5 minutes. After the application, you should not eat or brush your teeth for 2 hours. The course of treatment is from 8 to 28 procedures until the progress stabilizes. Remodentum and rinsing. Rinsing is carried out for 3-5 minutes. 20 ml of solution is used. Stages: cleaning teeth, learning to rinse with water, 3 repeated rinses on 1 minute. For hyperesthesia of teeth, rinse the mouth with a solution 4 times a week. The course of treatment is from 60 to 40 ranges. Remineralizing gels. Application methods with remineralizing gels for remineralizing therapy may be with mouth-guard applications or direct applications. Rox Medical Minerals Remineralizing Gel. This gel is a source of calcium, phosphorus, and magnesium. It has adhesive properties and retains well on the surface of the teeth. It forms a stable film that extends the exposure time of the active ingredients, which ensures their gradual penetration into the tooth tissue. GC Tooth Muse Remineralizing Gel for remineralizing therapy. It is a water-soluble cream containing casein phosphopeptide amorphous calcium phosphate. In the oral environment, this active component binds to biofilm, dental plaque, bacteria, hydroxyapatite, and soft tissue, delivering bioavailable calcium and phosphorus. Belagel Calci-Phosphor Remineralizing Gel for remineralizing therapy. Gel contains from gel and liquid. Gel contains a film former, phosphates, fluorides, natrium, etc. Liquid consists of calcium, magnesium, zinc. Simultaneously remineralizing enamel and transforming the film into a water-insoluble form. Method: apply gel to the teeth with a thin, even layer. Dry the resulting film with the airstream, then apply the liquid, and finally dry the resulting insoluble film which stays on the teeth for 5 hours. To preserve the film, it is recommended not to eat solid foods. 2-component drugs for remineralizing therapy and deep fluoridation. The principle of operation of the tool is based on the properties of active ingredients. The ability to inhibit the process of enamel demineralization, remineralization of defect with high concentration of fluoride ions, bacterial effect due to the content of cuprum ions, attachment of hydroxyapatite microcrystals to collagen with the precipitation of cuprum ions, which ensures the self-assembly of the tissue, increasing the resistance of teeth to carriers influences, which is adjuved thanks to magnesium ions. Gluftaret, 2-component drug for remineralizing therapy. The Gluftaret dental kit includes a liquid and suspension. Suspension: finely dispersed calcium hydroxide in distilled water with the addition of a stabilizer. Liquid is a blue solution containing fluorine and copper ions. Diaphan fluoride, 2-component drug for remineralizing therapy. The sealing liquid complex includes 2 liquids for primary processing. For the final, the preparation for primary treatment contains anhydrous magnesium fluoride silicate, anhydrous copper fluoride silicate, sodium fluoride, and the second composition includes highly dispersed calcium hydroxide. Individual prevention of dental hypersensitivity. Individual prevention of dentin hypersensitivity will be in choice of hygiene products, cleaning correction, using complementary oral hygiene products. Hygiene means for dentin hypersensitivity. Basic hygiene means to reduce hypersensitivity, the following agents are used, aimed at obturation of open dental tubules, fluorine-containing sodium fluoride, aminofluoride, sodium monofluorophosphate, and to reduce the excitability of nerve endings containing potassium salts, nitrate, chloride, strontium salts, chloride, calcium component, calcium glycerophosphate, hydroxyapatite, citrates, zinc. It should be noted that tooth-sensitive toothpastes are classified as low-abrasive toothpastes. Index of radioactive dentin abrasiveness RDA is from 30 to 50, or they can be gel. The action of fluorides is complex. They seal the dental tubules with salt globules, which are formed as a result of the interaction of ionized fluorine with calcium ions in the oral fluid. Calcium fluoride is formed. The use of pastes containing potassium salts as an active component allows you to get rid of only the symptoms. The concentration of potassium ions on the outer surface of the nerve cell membrane changes, and it loses sensitivity to various kinds of stimuli. The ideal remedy for the problem of hypersensitivity would be one that would have the following characteristics: speed of action, prolonged effect, independence from the individual characteristics of the oral cavity, lack of side effects, pleasant taste, and safety. Unfortunately, there is no such thing yet. Examples of basic hygiene products for the sensitive teeth. Mixidol Dent Sensitive. This paste is used to treat periodontitis with increased sensitivity of teeth and gums. It contains complex and potassium nitrate. The paste is low abrasive, so the process of brushing your teeth is more comfortable and non-traumatic for the gums. It is recommended to use at least 2 times a day for 4 to 6 weeks. Oral-B Sensitive Original contains 17% hydroxyapatite, which is identical to tooth enamel and perfectly strengthens the enamel, restores the natural protection of nerve fibers, and relieves increased pain sensitivity of the teeth. Silicon dioxide is included in the paste as an abrasive in a finely dispersed form. Sensodyne. The main active ingredient in Sensodyne paste is potassium chloride. During toothbrushing, the dentinal tubules are enveloped with potassium ions, and this prevents the conduction of pain impulses along the nerve endings. Rembrandt Sensitive. It is a low abrasion whitening toothpaste with anti-caries effect for sensitive teeth. It contains potassium nitrate. It closes the sensitive nerve processes that are exposed as a result of the reduction in the thickness of the enamel and dentin, and creates a kind of protective sheath. As a toothbrush for sensitive teeth, soft bristles brushes are recommended. Additional hygiene means is rinses for sensitive teeth. Prevention. In order to prevent the onset and development of hypersensitivity of hard dental tissue, dentists should, when examining patient, pay attention to the initial signs of diseases leading to hypersensitivity: periodontal diseases, erosion of enamel, enamel abrasion, wedge-shaped defects. Competently use tools for processing the root during the removal of calculus and polishing the tooth surface. Avoid excessive polishing of the exposed root during the removal of stains used to control the effectiveness of cleaning. Isolate the gums during professional whitening. Qualitatively and competently manufacture dentures and crowns. In order to prevent the onset and development of hypersensitivity of dental hard tissue, patients should maintain oral hygiene by following the correct brushing technique. Using a small amount of toothpaste while brushing your teeth. Because of toothpastes contain a foaming component that flushes calcium out of the enamel. Brush your teeth without undue effort and no more than the recommended time, no more 3 minutes. Don't use brushes with hard bristles. Use brushes with rounded bristle ends. Rinse your mouth with water immediately after taking acidified foods and carbonated drinks. Brush your teeth no earlier than 30 minutes after taking acidified foods and drinks. Avoid excessive or misuse of floss and other substances to clean the contact surface of the teeth. Don't damage the gums when using toothpicks. Thus, the prevention of increased dentin sensitivity will consist of several directions: timely sanitation of the mouth, correction of individual oral hygiene, use the preventive hygiene products, accurate work of the dentist, using prophylactic agents in the dentist's chair. Thank you for the attention. This video you can see as usual.